Hello, my name is Ian McCall, and this is another in the series of consultations in dermatology from the Australian Institute of Dermatology. Today we're going to look at a condition called amyloidosis. Now, it's actually a series of different conditions. I'm going to show you that in 1 minute. But you've really got to think of this condition as someone presents with unusual bruising or unusual pigmentation, usually associated with itching and rubbing the skin. Amyloidosis is characterized by infiltration of the skin by a protein called amyloid. Amyloid is deposited, or at least, amyloid's formed in most cases from plasma proteins. And it's a relatively insoluble protein when it's deposited in the skin. And it can be deposited in around blood vessels, and if it does that, it weakens the blood vessel and you can get this unexplained bruising. It can be deposited in the skin as infiltrated papules or as tumors, and sometimes in the other organs in the body. It can be deposited, for instance, in the tongue. You get a very large tongue. There's also amyloid deposited when you have altered keratin in the skin, and that can occur when people have the form of amyloid called macular or papular amyloid, which is secondary to chronic rubbing of the skin. And in those circumstances, you don't get any bleeding or the like, but you do get an increase in skin pigmentation. Now, let's have a little look at the different types of amyloidosis. And I think probably the best way to do this is to look at some images in a PowerPoint. So let's see if we can get that up. This is a condition called primary systemic amyloidosis, and here you certainly have amyloid deposited in the skin. You can see these sort of yellowish papules. Some of them almost appear to be occurring in lines here. You can also see there's hemorrhage into some of these papules. Now, if I was initially just looking at that bit of skin, I might have thought that it was a condition called lymphangioma circumscriptum, which is a disorder of lymphatics. But this, in fact, if I was to open these up, I would in fact find amyloid protein deposited just underneath the epidermis. This is the forearm of this particular patient. You can see these other little points where there's been hemorrhage into the skin as well. Now, in primary systemic amyloidosis like this, it's usually associated with underlying myeloma. Myeloma is a tumor of plasma cells, usually of the bone marrow, and you get abnormal immunoglobulins produced, and it's usually the light chain immunoglobulin that goes to form this type of amyloid protein. There's about 24 different types of amyloid protein, but they all have the basic core structure, and then I think different polysaccharides different polypeptide chains are in fact attached to them. They have this beta-pleated core. Now, here's another view of this particular patient. You can see the purpura perhaps just induced by scratching there in the skin. This is the other type of amyloid that you can see, though, and you can see the difference. These aren't smooth papules. They're rough-surfaced papules. And this is lichen amyloidosis. It's usually found on the front of the shins, particularly in Asian individuals. Also, it can be found in the external surfaces of the arms as well. And these seem to arise because of chronic rubbing or scratching of the skin. It's a different type of amyloid that's deposited here, and this type of amyloid doesn't infiltrate around blood vessels, so you don't get that bleeding that we showed in the primary systemic amyloidosis. So there's no weakness of blood vessels in this particular type of amyloid. Now, in this particular type, the protein itself is attached to altered keratin molecules in the skin. So they bind to anti-keratin antibodies that are directed at the altered keratin in the skin. And most of these cases are usually idiopathic. In other words, they don't have any other underlying disease, or they may be friction related as well. Occasionally, you can see an association with some connective tissue diseases, but not often. This is just a close-up to show you the keratotic nature of these amyloid papules. This is the other form of itchy amyloid you can get. It's called macular amyloidosis. It's because this is flat. There are no raised papules here. And this is supposed to show the rippled appearance of macular amyloid. It's often over the upper back, usually associated with chronic itch and scratching. And you get these reticulated lines or net-like pattern on the upper back. Here you have amyloid deposits again in the papillary dermis, and it's often in a globular form, and as I say, it doesn't involve blood vessels at all. The other form of amyloid you can get is tumoral amyloid. You can see the tumors, the nodules that are deposited in this area. Now, tumoral amyloid like this can also be associated with an underlying dyscrasia in the blood, but sometimes you'll get this form of amyloid without any sign of underlying disorder at all. So it's always an interesting one to see. This type of amyloid, occasionally though, it can go on and develop into the primary systemic amyloid, because the protein that's deposited here is a light chain immunoglobulin. So it's a curious picture. They may not, though, show myeloma, underlying myeloma, but they can develop it later on. If there's only one or two nodules, then the nodules can be simply excised. This is another case of tumoral amyloidosis. It's courtesy of the Washington University State. And you can see Washington State University. You can see the nodules that have arisen in this patient's nose over a period of time. And when they were biopsied, this was the picture that was seen. This is the amyloid eosinophilic material deposited underneath the epidermis here, with flattening of the epidermis. And this is just a close-up of it here. In primary systemic amyloidosis, which is associated with an underlying myeloma, this is the light chain form of amyloid. Then this protein can be deposited in the tongue, and you can get an enlarged tongue like this, and you'll sometimes actually see indentations from the teeth in the undersurface of the tongue. And as I say, it's these patients that will show evidence of pinch purpura. You just can run your finger along the skin here and you'll suddenly get bruising occurring, or just pinch a little bit of skin between your finger and bruising will occur here, because the amyloid is deposited along the small capillary blood vessels and weakens and damages it. This is an image courtesy of the American Rheumatology Association, and this shows the other characteristic feature. Look at this periorbital hemorrhage here. It's sometimes called the raccoon sign. And that can occur in primary systemic amyloid when someone coughs or sneezes and raises their intravascular pressure. That's enough to cause these small blood vessels to bleed and to present like this. And the same phenomenon can occur if someone's constipated. It can actually occur around the anus, just with straining and stress. They're trying to pass a bowel motion. They can get hemorrhage around this area as well. And you can see here the same sort of waxy papules that we had in that very first case on the arms, where there's primary systemic amyloid and the light chain immunoglobulin is deposited as this form of amyloid, as these sort of pearly papules. See, it's round the mouth here as well and round the nose. There's some up here in the eyelids as well. So when you see that type of amyloid with bleeding, it's primary systemic amyloid, and you go looking for an underlying myeloma. There's another case, and you can see the amyloids deposited in the skin. There's almost bullous amyloid here, and some of the blisters have peeled off, leaving these erosions. You can see the hemorrhage into the skin here. That would feel quite waxy. This is another case. It's courtesy of Dr. Namiyal Sidani from Iraq. Sorry, I managed to spell that wrong. In Global Skin Atlas. Here you can see the amyloid deposits around the skin with some hemorrhage. In the darker colored skin, it's not quite so obvious, the waxy colored nature of these. And this patient also showed this type of spontaneous hemorrhage into the skin due to the amyloid deposition around the small blood vessels. Another view of this patient, again you can see these waxy papules with hemorrhage into them in someone with primary systemic amyloidosis. And this was the amyloid deposited into the skin as these papules around the fingers and the sides of the fingers. I mean, it's a most interesting case. As you can see, there's some nail dystrophy involved from the process as well. You know, it's the waxy nature of these that tends to give them away and the association with hemorrhage. So, as I say, amyloidosis, it can also be associated with some inherited disorders. And there's a condition called familial Mediterranean fever, where you've got amyloid, and I think there's associated deafness in that condition. And that will respond to colchicine if it's given orally. What about macular and lichenoid amyloid? We said they were mainly due to friction and scratching. Well, these are the sort of rough surfaced papules that you'll see in the outer aspects of the arms and the legs over the shins. Well, topical or intralesional steroids can be used here, and it needs to be a strong topical steroid to flatten these and to break the itch-scratch cycle. The calcineurin inhibitors are things like tacrolimus or pimecrolimus. They can also be used. Puva is effective in this condition. And acitretin is one of the oral retinoids. It also can have a beneficial effect, but you know, this is quite a dangerous drug in terms of its teratogenicity, so it can't really be used in women at all. And what about those tumoral cases of amyloid, that case we showed on the leg? Well, again, if it's only one or two lesions, excision can be done, or laser ablation. But remember, we said that this type of tumoral amyloid is due to the light chain immunoglobulins. So even though they may not seem to have any underlying myeloma at the moment, you've always got to watch out for them developing that at some stage in the future. Then you've got primary systemic amyloid, treat the underlying myeloma. But there's also amyloid due to systemic diseases, and these can be chronic diseases such as infections, particularly TB, underlying osteomyelitis. I think even some underlying lymphomas such as Hodgkin's may do it as well. But in those particular conditions, even though it's due to systemic disease, the amyloid that's produced doesn't go around blood vessels. So that in that one where there's chronic underlying disease that the patient has, they don't have those skin features. They don't have that hemorrhage. And the problem with primary systemic amyloid, though, where the problem is a myeloma, is they do have the hemorrhage. And this amyloid protein can be deposited in all sorts of internal organs, including the heart and the brain. So amyloidosis can affect a variety of other structures, and particularly the kidneys. Often in primary systemic amyloid, they may present with the nephrotic syndrome. But the nephrotic syndrome can also occur in patients where the amyloid is due to underlying chronic disease, such as osteomyelitis and other even inflammatory arthritis. And that familial Mediterranean fever, they can also get some kidney problems associated with that as well, because the amyloid that's produced as an acute phase protein amyloid. But remember, that type doesn't have skin findings. They can have the renal findings, they can have some gastrointestinal findings as well. So we've said here colchicine, it can be used in some amyloid secondary to these underlying diseases, and certainly in familial Mediterranean fever. Amyloid colchicine can be used then. So amyloidosis, it's an interesting disorder, or an interesting protein. You can see that the presentation is either going to be, if it's primary systemic with unusual bruising, or If it's macular amyloid or lichen amyloid, it's going to be with itchy, pigmented papules, certainly on the limbs in lichen amyloid, and that rippled pigmentation on the upper back in macular amyloid. But the big one to watch for is the one with primary systemic amyloid, with the waxy papules, the bit of hemorrhage, and the potential for involvement of the kidneys with nephrotic syndrome and the like. So it's an interesting condition, amyloidosis. We don't see it all that often. We certainly see the macular and lichenoid amyloid, these ones. We'll see these reasonably often. But primary systemic amyloid we don't see too much. Renal physicians tend to see a fair bit of amyloidosis because of the kidney involvement. And if there isn't skin signs there that they can biopsy, it usually means they have to do a kidney biopsy. I didn't show any pictures of the biopsy material other than this one down here from the Washington State University case. There are special stains that are done to show amyloid, the Congo red, the crystal violet stains, and they're quite colorful, those, but I don't unfortunately have any pictures of them. It's one of those diagnoses, by the way, that a pathologist can miss. It can be quite subtle sometimes. So if you're considering amyloidosis, always make sure you alert your pathologist so that they will carry out the special stains to try and highlight any amyloid that's in fact there. So amyloidosis, interesting disorder. It can mimic a lot of underlying diseases. It can be seen in general medicine because of the involvement of all these other underlying organs. And watch for multiple myeloma in patients who have primary systemic amyloid and who are presenting with a big tongue or with bruising, or sometimes even with hoarseness where amyloid infiltrates the vocal cords. Interesting condition. Thank you very much.